So thank you very much, Barbara, for that introduction. You will remember that it seems only 5 minutes ago in March, we had a similar exercise. It's a shame we can't meet in person for educational and scientific meetings, but some of the members of your medical and scientific advisory group who supervise the blood film and parasitology, morphology, external quality assessment exercises, volunteered to run a session which I think went successfully. We looked at some examples of emergencies when the haematologist had come to the rescue. Of course, we're in the middle of lockdown then with our masks on, and I know some of us are still wearing masks for a lot of the time at work, but I think we've liberated ourselves a little bit. So we've entitled today's session The Haematologists Unmasked. And we thought for a unifying theme, we would use the bane of our lives, really, which is the fact that our user clinicians are often very frugal with the information they give us about the tests they're sending. You know, we ask, and we always provide with our specimen request forms or our electronic requests, space for clinical details. I mean, it does enable us to prioritize what we do. I mean, after all, if everything is urgent, then nothing is urgent. We can only just do work in the order it comes in, and we can work as fast as we can. But there are situations where we need to know if we have to drop everything to deal with a case of somebody's got is hemorrhaging to death in the emergency room, or if somebody has got a clinical presentation that looks like it might be acute leukemia and they've got a cerebral hemorrhage. We need this information in order to prioritize. We also need it to work efficiently, and we can also be much more useful about how we comment. I think one of the things we could be doing is to say, you know, what instead of asking for clinical details, we should ask people, what is the question you want this investigation to answer? We can, if we've got an EDTA specimen, add blood film examination, flow cytometry, molecular investigations such as JAK2, we can do lead levels, we can do all sorts of things with a specimen if we've got information that helps us to be helpful to the user. We don't need to demand manage full blood counts, but the full blood count is a part of the general examination of any patient. But we do need to demand manage films. We're not going to make a film on everybody with a normal blood count, but we might well want to make a film of somebody with a normal blood count who's got splenomegaly, for example. It enables us to check that we have done the right test, and it's just courteous to give clinical details to a colleague. And of course, as participants in the external quality control exercise, we're very used to receiving material without clinical details. We do it deliberately because we are trying in isolation to test people's morphological skills, and we don't want them to be able to guess what the answer is from information provided. But in real life, we need to triangulate. We need to have numerical data, we need to have the morphological picture, and we need clinical information, and we may want to add other tests as well. So we all know this, but we're just going to give you one or two examples of situations where perhaps we didn't get the best steer from the clinical details, and it may have misdirected what we did. So here's me with my mask off, and I'm going to go first with my presentation. And here's me imagining that you know, I might have another mask on some of the time when I'm not told what clinical information I need. So I'm going to tell you about a 72-year-old lady in the order in which I came across her material, and you'll see why, I hope, to make the point later. And it wasn't that we got no clinical detail, we got a minimal clinical detail. We got relapsed lymphoma staging. And I was in the regional referral laboratory where we get bone marrow trophine specimens in for immunohistochemistry. And often if we're looking at marrow to find out whether lymphoma is present, it's important to look at the bone marrow trophine, even if we've had negative aspirate material, normal blood counts previously. Often tumor in the marrow is trapped by fibrosis and doesn't necessarily come out with a liquid specimen. And indeed, we had an aspirate specimen for flow cytometry a couple of days previously, and I'll come back to that in a moment. The other information I did have was that the lady had a mild pancytopenia. You can see the figures there. When it says relapsed lymphoma, I think, okay, that means she's had lymphoma before. Perhaps we can get more information by looking back in our records, but I found no help there. We didn't know, we had no previous detail about this particular lady. I'm going to quickly show you some pictures of her bone marrow trophine. Now, not that I know with this audience, trophine material is perhaps unfamiliar, but we're going to come on to aspirate material and peripheral blood material shortly. But we've got a nice bone marrow core here. It's rather hypercellular for a 72-year-old lady. There should be slightly more than 50% of the space occupied by fat in these globules here. And so we can see that there's a lot of cells. There are megakaryocytes here. There are some aggregates of small lymphocytes that we can see at low power, and perhaps at slightly higher power here. And we can start to see, there's a scattering of eosinophils around as well. Lots of megakaryocytes, some maturing granular poiesis, lots of nucleated red cells. But these aggregates of lymphoid cells, they're not paratrabecular, they're quite small, they're rounded, they could well be reactive, or they could well represent recurrent lymphoma, which was the clinical question. A low-grade lymphoproliferative disorder, particularly perhaps a marginal zone lymphoma, might look like this. And we can investigate, and indeed we did investigate with immunohistochemistry to find that these were a nice mixture of T cells and B cells. They weren't particularly B cell rich. They didn't have an abnormal immunophenotype, and they looked like they were reactive. When we get to slightly higher power, you might start to see this curious stippling that appears to be in the background. If we get even higher, it's quite striking. Look at all this. And if you've never seen this before, you might think this is some kind of staining artifact. But this is an absolutely characteristic appearance. Once you've seen it, you'll recognize it again. These inclusions in the macrophages, these are inclusions in the macrophages of this bone marrow, and it immediately caused me to go through to the flow cytometry lab and say, where is the aspirate smear from this patient that we're looking at? And when we looked at that, you can almost start to see the detail here of these structures, but you go back to the aspirate, and all will be revealed. The aspirate was cellular and particulate. It didn't have an excess of lymphocytes. We'd had a quick look at it. We put it through the flow cytometer. We found no clonal lymphoid proliferation. And so there was no evidence of lymphoma. But if you went hunting and looked for macrophages in this bone marrow, they had these rounded inclusions. And these, as many of you will know, are amastigotes of the parasite Leishmania donovani. This lady had visceral Leishmaniasis. She was thought to have had relapsed lymphoma because, in fact, 3 years previously, she'd been treated for mantle cell lymphoma at another institution, which is why we had no record. And she was treated with chemotherapy and an autologous bone marrow transplant with intensive chemotherapy. And she had done very well, and she'd gone off, and she used to enjoy spending time at her holiday villa in Portugal on the south coast. And she'd come back, she'd complained of night sweats and fevers And when she was examined, she had a large liver and spleen. And not unreasonably, the treating physicians thought, she's got recurrent lymphoma, poor lady. She's relapsed after her transplant. And this tells a completely different story. These amastigotes, the nucleus and a kinetoplast, rod-like structure with a very rounded, these look like platelets in the background, but these are actually free amastigotes in the bone marrow. And then when we ask for a peripheral blood specimen, here they are in the peripheral blood. So Leishmaniasis is transmitted by the sandfly, the sandfly, which is phlebotomine sandfly, from the Greek, cutting for veins. This is a professional blood taker. And the meal, rather like with malaria, the meal is transmitted from the gut of the insect into the bloodstream. And if you think about it, it's very rare to see them in the peripheral blood, but they must be in the peripheral blood, otherwise the disease wouldn't exist. Because, and here they are in neutrophils, where they normally proliferate in monocyte macrophage lineage cells. And the importance of this is that this is fatal in an immunocompromised patient. It's readily treatable and curable when it's recognized and appropriately managed, and it's easily missed if you don't look for it. And we had looked at this material without seeing it, perhaps because would have been, if somebody had said, oh, here's an immunocompromised patient with fever, organomegaly, and a travel history, we might have got there more quickly. And I have to say, it is, on the few occasions I've diagnosed this condition over many years in haematology, it's usually been a surprise. We're often asked to look for it when we don't find it by the infectious diseases team quite properly. But we've discovered it in haematology patients and other immunocompromised rheumatology patients by accident. And you think, thank heavens for that. And I wonder whether, we've ever missed it. And although it's often a marrow finding, I would I make no apology for showing it to an audience of medical laboratory scientists. The first time I came across this case, one or two of my medical colleagues had missed it, and the late Roger Flemons, who was the chief medical laboratory scientific officer at Frank Hayhoe's laboratory in Cambridge, had spotted it. This was when I was a registrar, and I learned more from him about bone marrow morphology than anybody else, except for one person, who is our next speaker, who's Professor Barbara Bain, to whom I'm just about to hand over.
Thank you very much, Peter. Here I am, masked and unmasked. And I'd like to acknowledge John Bertham's contribution. I'm sure the Australians among you will notice that he's managed to photograph a koala in a blood film. If you're lucky, you might see a koala or some other interesting shape. However, you may also find a solution to a diagnostic problem that you haven't even been told about, which is what happened in the patient that I'm about to tell you about. Sometimes you know what the problem is that you're trying to help solve. Sometimes you're given no clinical details, but what can be even worse, you may be given the wrong clinical details, and that might be quite misleading. So this patient presented with fever and symptomatic anemia, quite a severe anemia, as you can see, and she also had biochemical evidence of haemolysis. And she was identified on the information technology system of the hospital and on the data we received as being an adult female of Indian origin. And we were asked to examine a blood film, and we obviously would have examined a blood film with an unexplained hemoglobin of 70. And I've just got one photo of the blood film, so there's quite a lot to see here. So for a start, there's a normal neutrophil. The patient appears to be anemic. This film looks consistent with the hemoglobin of 70. The blood film spreads more thinly because of the low viscosity when there's anemia, so you should be able to correlate the hemoglobin and the appearance of the film. The platelets look normal. However, the red cells look far from normal. There are some fairly large normal looking cells. Perhaps some of these are even a little macrocytic, but they're certainly not small. But then there are a lot of cells which are small and dark. So they've got reduced central pallor or absent central pallor. So you have to first ask yourself, are they spherocytes? Which they're clearly not. There's the odd one that looks roughly spherical, but the dominant one is not. And these are correctly termed irregularly contracted cells. Like the spherocyte, they have a high MCHC. But then the other curious thing about them is that a lot of them have got some empty cytoplasm. And these are often called blister cells, or if this empty cytoplasm occupies half the cell, then you can call them hemighosts. But there's an even more intriguing finding, which many people are unaware of, and that is that within this empty area, there are some inclusions. So this is the best example here. And there's a small one there and a couple of little ones there. And you can see things that appear to be sticking out of the cells, as in this one. So we've got irregularly contracted cells with inclusions, and I think we've got polychromatic macrocytes as well. So this film really is very typical of oxidant-induced hemolysis, either occurring in a patient who is glucose 6-phosphate dehydrogenase deficient and who's been exposed to an oxidant stress, or a patient who's got normal red cell enzymes but has been exposed to quite a potent oxidant stress. And the commonest, I think, in hospital practice is dapsone, and you will often see a few irregularly contracted cells in your dermatology clinic patients who are taking dapsone. So this was obviously an acute onset, and we suspect a G6PD deficiency. But the problem with that was that this was a female, and this seemed a bit severe for a female. And just before we get rid of this screen, here's another very fine example. So these are Heinz bodies, not on a special Heinz body prep, but seen in a routine Magrin or Giemsa stain. So which was it? Was it an exogenous oxidant, or was it a defect in the pentose shunt? So we did a G6PD assay, and this actually confirmed deficiency. So this was a bit puzzling because the hospital computer system said that this was a female. So in what circumstances might we see quite striking hemolysis in a female? So the female may be homozygous for G6PD deficiency, or compound heterozygous, which means that she's got two defective genes, but they're not identical. Homozygosity is not unlikely if you're dealing with an area where cousin marriages occur, because then the same mutation may be inherited from both parents. In heterozygotes, you can get hemolysis because in any one cell, one of the X chromosomes is inactivated, and this is called lionization. And if you inactivate the X chromosome with the normal G6PD gene and you leave the defective one there, then that cell will be prone to hemolysis. And as this is a random process, on average, you'd expect about 50% of cells to express the deficient gene, but that can be quite variable. The other circumstance in which we see this is when a patient has had a hematopoietic cell transplant from a male donor who happened to be G6PD deficient. And this can be among the clinical details that are not revealed to us. And the transplant may have been done in another hospital, so it may not be in our records. G6PD deficiency has also been described in Turner syndrome when apparent females have only a single X chromosome. So the next question was there something that we hadn't been told? This neutrophil was typical of this patient. There were no drumsticks, and you would expect drumsticks in a proportion of the neutrophils of a female, these being the inactive X chromosome. So why didn't she have any drumsticks? This is what the drumstick ought to look like. They're very easily recognizable, and she didn't have them. So we made some further inquiries, and it was disclosed that this patient was actually a trans female. That is to say, she was genetically a male, but she was regarding herself and was being treated as a female and was being recorded in the hospital records as a female. So essentially, her red cells have got the characteristics of a male with G6PD deficiency who's got only one X chromosome, and that X chromosome is defective. So if patients want to alter their gender, it can be quite confusing to the laboratory if you don't know what the person is genetically. So just be alert to all these curious causes of unusually severe hemolysis in a female due to G6PD deficiency. Thank you, and I shall pass on to the next speaker.
So this was one where we got some incredibly helpful in clinical information, but sadly the information we got was really only very helpful in retrospect, and I'll come to that a bit later. Again, just to recap, there's me and my cat praying some increased social distancing after spending too long in a photo session this year. So this was just another day in the laboratory, and I wasn't in the laboratory at the time, but I think Ben was our microscope, received a blood film made from a child who was attending a paediatric clinic. The counts that were sent across to us were, I believe, unremarkable. But some toxic granulation of the neutrophils was noted. Now I say toxic granulation, but it wasn't, but we'll come to that in a moment. Let's first review what typical toxic granulation looks like. So here's a neutrophil in someone who's been treated with G-CSF. In fact, there's a typical hypergranular neutrophil which occurs in that context. The hypergranulation is in fact a persistence of the dense staining primary neutrophil granules, which usually fading by the time a normal neutrophil gets to maturity. But in toxic states, these are retained. And there appears these particularly dark granules in amongst the normal, slightly paler, more red granules. But no, when you're looking for a toxic granulation, it's just not just the granules themselves. It's also the nucleus, which may be less shifted, the chromatin may be a little bit more open, reflecting the more rapid maturation. The cytoplasm is often larger and more spreading, and you may see some doughy bodies, these pale blue inclusions within activated neutrophils. I'm not going to point one to one on this slide because I don't think there is one, but they can certainly be seen. So what did we see on this one? Well, here's what we saw in this one. Our neutrophil had many granules, but was by no means typical. And the question Ben asked himself was, is this consistent with neutrophil activation? What we see here is a neutrophil which is a fairly normal looking nucleus with dense chromatin, but very, very intense blue granulation. You might almost wonder if this is a basophil, but these granules are actually very, very discrete and maybe surrounded by a slightly paler halo. And here's an even more granular one on a further field. The question was, this is too granular, were these wrong granules? For a child attending clinic, if this was toxic granulation, it would cause some remarkable concern about the illness that might be underlying this. So what Ben did too was first of all to recognize this was unfamiliar. If he's looked at enough Daniel's pictures, then you recognize what's normal and what you don't often see. And he recognized unfamiliarity. And he then made the next step, which was to act on that unfamiliarity. And his action was to pass it on to Rish in our lab, who had a look as well. And now I don't really know precisely what happened because I wasn't there, but I think on looking around the film, you find other elements here. This is a particularly unusual one in which the granules are almost impossible to find. So the granules are very possible to find. The cell itself, the nucleus is impossible to see. It just looks like a lump of granules. Other cells are more recognizable. Here's a large lymphocyte sitting next to a neutrophil. You might argue this is a large granular lymphocyte, but the granules are unusually dark and coarse looking. And again, they're surrounded by this faint pale halo, which you can see in the other cells surrounding it. Not typical, but okay, this might be a normal large granular lymphocyte. Here's a monocyte. Again, granules can occur in monocytes, particularly in the slightly less mature ones. But again, these are very dense, very active, and again, these very, very large, dense blue granules. But one place they shouldn't be is in cells like this small lymphocyte. This is definitely not right. A small lymphocyte should not have this very obvious granulation. So something was wrong. So what are your resources when something's wrong? Well, Rish went to the very, very best resource we knew in our lab, which was to ask an expert. Now, Barbara may not realise she was actually asked about this case because she doesn't sit in the corner of our lab awaiting questions. But what does sit in the corner of our lab awaiting questions is Barbara's book, Blood Cells: A Practical Guide. And on looking through it and in correlating with the clinical information we had, she was able to make a diagnosis for this cell. At that point, we looked back at the clinical information, and the clinical information was a helpful phrase, query MPS1. Now, in retrospect, MPS1 stood for mucopolysaccharidosis 1, otherwise known as Hunter's syndrome. And in this condition, we see these cells, the Alder-Reilly anomaly. Now, it's the Alder-Reilly anomaly because it occurs in a range of different conditions. It's not simply diagnosed with one condition, but it can range a range of mucopolysaccharidosis states. It's described by Alder and Reilly, not together but separately. Alder was Swiss and described in 1939. Then the American pediatrician Reilly described it in 1941. And it's an inherited deficiency of lysosomal enzymes. Because these lysosomal enzymes are deficient, then the partially degraded mucopolysaccharidosis remains inside the lysosomes, and we see these as granules. In actual fact, they should be called inclusions because they're not actually granules as we recognize them. They're inclusions. And one of the key features, if you're looking for them, is to actually go up to the high power, where you see them surrounded by this very, very pale membrane. So you see the darts in the middle, but surround this area of pallor. And so that's a inclusion body within a lysosome. If you're trying to diagnose this, the things you should look for are particularly dense and uniform inclusions in otherwise non-activated neutrophils. You should then look around, and you may also find them in the lymphocytes, and you'll definitely find them in the monocytes. And then look for the halo. If you've got a good enough microscope, you should be able to see the nice pale halo surrounding them. It shows they lie in the lysosomal membrane. So last two slides. Lessons for this one is treasure the unexpected finding. As I said in my last case I did this presentation. When you do find unexpected finding, look for further information, be it from a colleague, a book, or another person. And clinical information can occasionally be helpful, but sometimes it requires you to put it into Google and find out what MSP1 actually means. And certainly I don't think I mean too much to most people outside of a specialist pediatric laboratory. And finally, don't be afraid to suggest a diagnosis. In this case, a query MSP1 became a likely MSP1 after Rich spoke to the pediatricians, and then became a definite MSP1 once the genetics was received. So finally, just to popularize our Instagram site hematography, we will be putting this case up at the end of this this session or sometime the next day or so, and probably also put Michelle's one up a little bit later. So thank you very much for your attention. I shall now stop sharing and I will pass on to the next speaker, who is Michelle Brereton.
A&E departments, and although this case I'm going to talk about is rare, these cases do happen, and obviously anyone can come in through A&E anytime, night and day. So people who come in out of our shifts always on the alert. In my lab, the current and soon to be replaced IT system doesn't exactly encourage users to provide useful clinical information. And perhaps as laboratories, we also probably fail to get across our message to users how important just a few clinical details are for us. And I agree with Peter's phrase that perhaps sometimes if they could just give us what they were looking for in the test, that would give us a clue as well. So this gentleman has come in through A&E, and our favourite diagnosis from the emergency department is unwell. So to get acutely unwell might be considered a bonus, but it might also add to us that there is perhaps an air of urgency here. So the full blood count had a mildly raised white cell count and a raised RDW, red cell distribution width. So a blood film was done. At that point, the hemoglobin was virtually normal, and there was no real anything unusual about the rest of the indices at that point. Oh yes, I can move the slide forward. That's another plus. So this is a low power view of the blood film as it appears. And there's one small platelet clump, but otherwise I think the platelets are there, and we can come back to those in a bit. But looking around, the white cell count is confirmed as being slightly raised. The lymphocytes look probably slightly large with that sort of motile cytoplasm, and I'd probably class that as a sort of reactive appearance. And I'd agree with that from the neutrophil that I can see. There's also a damaged or a disintegrated neutrophil. But the main focus of the film is going to be the red cells, but it's a picture, an altogether picture. And so from the low power image, we sort of get a possible view of possible dimorphism almost, because there clearly are some normal red cells there with the nice central pallor that we'd expect. But amongst the normal red cells, there is a variety of extremely dense cells with no central pallor, and we'd call these spherocytes. But interestingly, spherocytes seem to come in different sizes, and there are some quite small ones, which I'd probably call microspherocytes, although I don't think there's a specific size definition for that, but they're of interest. There's also some debris in the back of the slide as well. So looking a bit closer, we can confirm that sort of reactive appearance of the white cells. And looking around, we can also agree perhaps that the spherocytes are of varying size. There's a few irregular contracted cells, there's one highlighted with the blue arrow. There's the odd echinocyte and burst cell, crinkly cell, the echinocyte, red arrow. And I've highlighted some debris, which is clearly red cell debris from red cells with a green arrow. And we can see that there's a range of spherocytes sizes. Interestingly, there's not a great deal of obvious polychromasia, I don't feel, in this film. And that suggests to us that this is actually an acute hemolytic episode. If it had been chronic and been going on for some time, with all those spherocytes there, we would have expected to see a number of obvious polychromatic cells and probably some nucleated reds, but there are none in this picture. So we're looking at something that's an acute phase response, and we really would want to act on that and consider these findings. Having a closer look at high power and trying to get a closer look at some of the odd things that are going on, we can almost convince ourselves that we might see how the microspherocytes are being formed, in that we've got a bud-like protrusion coming from some of the red cells, and I hope I've circled them in green that you can see. So we're actually witnessing here the red cell membrane structural problems with it, and its attempt to restructure itself, to reclaim the cell and keep its cell contents intact. But if you look around, you'll see that there are some very microcytic fragments. So there's a little green arrow where clearly cell content has been lost. And this is really quite a severe response. Equally, this person has a spleen. So as these cells go through the spleen, all these spherocytes are going to be removed, and this person's hemoglobin is going to fall pretty quickly. So although we've caught it now with a fairly normal hemoglobin, we can see, looking at the film, that is not going to stay the same for very long. This is just another area of the film, and just doing it again to try and highlight this area of these spherocytes and the budding appearance of them. And also to remind ourselves that depending on how we all do our platelet counts, the platelet count might need some consideration. There's in the green circle, you'll see that there is a platelet there easily the size of that small spherocyte. So that would need some sort of flow count or optical count depending on your analyzer. And taking alongside the fact that there's a bit of clumping, it's important that when reviewing a film that you would reflect on the platelet count in that blood film report, so that you would cover that. Obviously, the main impact is to get on the phone about the spherocytes, because this patient is going to need a blood transfusion. So considering the morphology and the problems with the membrane, there are different cases where microspherocytes and cell budding can be seen, and they're all to do with spectrin in the membrane, which normally would keep the membrane intact. So problems with spectrin could evolve these conditions that we've got here. So I've just shown a hereditary parapoikilocytosis, which is unlikely to be in this case because it's the sort of thing that you're going to find in a neonate. But these are disorders associated with a mutation or lack of a gene for spectrin. And as I say, you come across these in neonates where you see wildly abnormal, different shaped cells, and they would include the microspherocytes as well. On the far right, we see what would happen when a sample is left on the back of a car while being transported in the sunlight from an outside unit back to the hospital. And it's said that a sample left for an hour at 46 degrees C will create this effect. And again, the membrane's broken down and you can see the budding effect. But on that sort of a film, you're going to get fast changes to all the parameters, and you're going to be very suspicious of that sample transport. And in the centre, didn't have a pitch myself to hand. I've gone to the Kawakami and Ito paper, which looks at Clostridium pemfringens, or as Clostridium welshi, as I used to call it, which also has the same effect. That would also have a septic reactive picture, but again, we would see the microspherocytes and again, a massive hemolytic response. That also would require an urgent phone call. But looking at that morphology, and although we don't know anything yet about our patient, it is none of those three. It is, in fact, a case of severe burns. So the patient had had an accident at home with a chip pan, rare these days for those people who have modern appliances, which had set a fire, and he got 70% burns. The key features are the tiny red cell fragments, as we've discussed, giving budding to the microspherocytes. And the damage to the cytoskeleton protein spectrum gives us the unstemmable membrane. Our fear, of course, is that the spleen is going to remove all those cells and that a transfusion is going to be needed. So really, there's a two-way thing here. If we're told that information right at the beginning, that it's a burns patient, then we should be treating this extremely urgently. Even with a fairly normal count, we want to look at the blood film and then get that information back to the clinical team. I'd also like to thank the NEQAS team for inviting us again to do this. I hope it's been an interesting case. It is the sort of case that is rare, but does happen, and we all do see. And again, we've got some cases on our haematology, etc. website or on the haematography. So thank you, and I'd like to hand back to, I think it's Barbara who's going to take over.
Yes, yeah, I will take over, and thank you very much, Michelle, for winding up that session, and thank you to all of the speakers who have spoken today and presented us with these absolutely excellent cases. We have 10 minutes for some questions, so if you still want to put some questions in, please do. I'll start off, first of all, there was one that did go into the chat, but I think it is worth asking, and I think it's directed probably for yourself, Professor Bain, which was just to ask to clarify compound heterozygosity in a G6PD in G6PD in a female. I wonder if you could just clarify that for the question. It came from Thomas Swindells.
Thank you. Yes. If somebody is homozygous for a defective gene, then that means it's exactly the same gene on both chromosomes. A compound heterozygote means that both genes are abnormal, but they're genetically different. So it's functionally the same as being homozygous, but it's just that the DNA sequence is not the same. I wonder, might I be permitted to make a very quick comment on Michelle's case? I can't
yes,
hear,
please. Yes, please do. Please do.
Thank you for those very attractive pictures. There was an interesting thing also to note, and that was that your photos, several of them showed what I call a microdiscocyte, which is about the same diameter as the microspherocyte, but it's got central pallor. And you only see that, in my experience, in burns, because it's budding off not only things that are spherocytic, but things that have got enough membrane that they can then turn into a tiny little disc. So I think if you get a film like that, it's worth looking for a microdiscocyte as well. Thank you for letting me comment. Thank
you, Barbara. Now I'll go to the other questions. The first question comes from Cheyenne Box. She hasn't said who this should be directed to, but I would suspect that probably Prof. Bain, you can start on this one. Can you outline the differences morphologically between atypical lymphocytes and atypical mononuclear cells, e.g. as in EBV, and are there any differences? And also, as far as EBV, is the correct way of reporting these lymphocytes as atypical mononuclear cells?
Right, okay, so this question takes us back a fair way in history. The cells in infectious mononucleosis were initially called atypical mononuclear cells because people didn't know what they were. They weren't sure if they were lymphocytes or strange monocytes or what. And then as time moved on, we got immunophenotyping, and we discovered that these were all actually lymphocytes. So it's now more appropriate to call them atypical lymphocytes. And there's an international group that advises on morphological terminology, and they suggest using the terms atypical lymphocyte appears reactive or atypical lymphocyte suspect neoplastic, because sometimes you can get a cell which in something like mantle cell lymphoma, for example, which doesn't look all that dissimilar to the ones you would get in a viral infection. So I think the first thing to do is to notice them, call them atypical lymphocytes, and then think, looking at the overall picture, what is most likely, and suggest that possibility.
Thank you. The next question comes from Stephen Hibbs, and I'll leave it open to our panel to decide who would like to answer this. First of all, what are the views on quantification of fragments in working out the likelihood of TTP or other TMA?
Well, I'll have a go if nobody else is talking. There is an international consensus document which suggests how many fragments you need to suspect something like thrombotic thrombocytopenic purpura. But I've seen cases with very, very few fragments, and one which I published with a colleague from India was a patient who was given platelets very inadvisedly and overnight became comatose. And she had very few fragments, but she had an Adam TS13 well under 10%, and she clearly had TTP. So the more there are, the more significant there are, but don't rule out the possibility of a diagnosis just because there are not enough of them.
Did you want to add anything to that, Dr. Carey?
Yeah, I'm glad you leapt in. Your comment is much more authoritative than mine will be, but from personal experience, I think one of the hopes when you start to offer a quantitation is that you might be helping to work out how, once you've made a diagnosis of TTP or HUS or other microangiopathic hemolysis, your clinical colleagues will be managing them with plasma exchange or other or immunosuppressive therapy or various approaches. And one of the things is, is it getting better or is it getting worse, and can we help? And there are various things you can do. You can look at the reticulocyte count, you can look at the unconjugated bilirubin level, you can look at the LDH. And the other thing, if you've got a quantitation, you can look at the number of fragments that you're seeing, or the proportion of fragments that you're seeing in high power fields under the microscope. But again, as Barbara has just pointed out, I think unfortunately it doesn't always correlate as well with the clinical severity at any particular time. And if people are having plasma exchange with machines that are mincing up the red cells, you may get, you know, fragments for other reasons. So although I think we are able to offer quantitation, and we should, and there is a very clear internationally accepted guideline for doing so, and we do in our laboratory. When we make a diagnosis, we also offer a quantitation. But I think it's sometimes it's not always completely correlating with the clinical picture. You have to be using it in a guarded way.
Thank you both. Next, well, it's probably an observation, but it would be useful to know what people's views on this is. It's from Claire Michelle Neville, which said, certainly with Professor Bain's case, it would be useful to have the limbs state the gender at birth. And I don't know whether this is going to become an increasing issue, you know, going forward as. Because you know, we do have a situation now where, you know, there are issues around things like transgender reference intervals and actually understanding what the difference between you know, the actual gender at birth and somebody's chosen gender. I don't know if anybody would like to, from the panel, would like to make any observations on that. The next question going on from that is from Andy Weir, which was about Peter's cases, and said, are there any case where Leishmania is seen in the bone marrow only and with no peripheral blood involvement at the time?
I would say certainly. I think it's very unusual to find it in the peripheral blood, and it is it's normally a bone marrow observation. I think, you know, in a way, the trophine is almost, if you compare it with looking for malaria, the trophine is a bit like a thick film. You will be alert to the fact that it's likely to be there because that curious stippled appearance, it's tantalizing because you can't actually see the detail of the amastigote, but you can just know, once you've seen it once in your life, you think, oh, that appearance alerts you to the presence, and then you go back to the aspirate material. And what you have to do, if somebody's clinically suspecting visceral leishmaniasis, that's a reasonable indication for bone marrow examination. In this day and age, you can look for it molecularly, probably more sensitively with PCR techniques and so on. But, you know, going back to, if you'd only have to go back 10 or 15 years, and really the only way you would make the diagnosis with any certainty is getting marrow out and hunting around till you found several macrophages. And if it's there, you will find amastigotes, but they tend to be just in the macrophages. A case like ours with an immunosuppressed lady, there were free amastigotes around at the background of the marrow aspirate. And when we looked hard, we found it in the peripheral blood. But it's very, I don't know about Barbara, Barbara Bain may have more experience of finding it in the peripheral blood. It's not something we often see. As I say, I mean, it must be that it's there, because otherwise the disease wouldn't be transmitted by the sandfly. The sandflies aren't getting them out of the marrow, they're getting them out of the blood. But I have to say it's very rare that it's a peripheral blood observation.
Yeah, I've had the same experience that you had with this case, that you see it in the marrow, and then you see a jolly lot in the marrow, and then you think surely there was some in the peripheral blood, and you go back and search and you can find a few. It's true that they're only in the macrophages, but often you actually rupture some of the macrophages when you're spreading the bone marrow film, so you may also see them apparently free in the marrow. And the other reason why the clinical suspicion is rather important is that it's actually more sensitive to culture the bone marrow rather than just to do a film and examine it. So if you know the clinicians are suspecting leishmaniasis, then a culture should always be done.
Sorry, I muted myself because there's a very noisy vehicle outside. The next question comes from Phoebe Sturges, who has asked how you would quantify smear and smudge cells during a manual differentiation, doing a manual differential, and why should you do that? again, I suspect this is one that Professor Bain, you have your microphone on.
Oh yes, well I have fairly strong feelings on this. I think if you've got a chronic lymphocytic leukemia, you know what the smear cells are, so you should just count them as lymphocytes. The reason it's important to count them is that if you just ignore them, then you will underestimate the number of lymphocytes and overestimate the number of neutrophils. If you don't know what they are, then and there's significant numbers, then you have to give them a separate category of unidentified cells. But either way, you've got to count them, or the percentage and the absolute number of everything else will be wrong.
Thank you.
Can I just add to that? The nowadays modern cell counters are pretty good. I mean, 10 years ago, they used to vote out a lot on CLLs, and everybody was used to doing manual differentials on CLLs. But nowadays that's more unusual, and the cell counters are fairly accurate on that, because in theory you're making the smears when you make the film. So often if you're doing a manual film and your neutrophil count then is not in line with that from the analyzer, you probably need to be more careful on counting them.
Thank you, Michelle. Michelle, the next question is for you, is from Andy Weir. He, just out of interest, was wondering what if you recollect what the platelet count was on your case, approximately.
Sorry, press the wrong button there. Still not quite got this. The platelet count was normal. It wasn't done, the film wasn't done because the platelet count had dropped at that point, or because, and we do have an optical platelet count, so we would have got an accurate platelet count. It wasn't falsely raised due to the spherocytes. It wasn't an impedance count. I don't have the details, but if it had been an impedance count, I fear that might have added to the platelet count.